Good afternoon, friends. I welcome you all again to this interactive session of dermatology. Before we start with our afternoon session, I would like to again introduce you to the dignitaries who have joined us. To my left is Dr. Neeti Khungar, who is a Senior Consultant, Department of Dermatology, Vardhaman Mahavir Medical College, New Delhi. To my right is Professor R.C. Sharma, former Director, Department of Dermatology, Lady Hardinge Medical College. To his right is Dr. Somesh Gupta, who is again a Professor in Department of Dermatology, All India Institute of Medical Science. To his right is Dr. Sood, who is the Executive Director of National Board of Examinations. Now I would request Dr. Neeti Khungar to enlighten us with her lecture on the diagnostic procedures in dermatology.
Dear students, I welcome you back. In this postprandial session, we will be discussing one more aspect of the clinical procedures in dermatology, and that is the diagnostic procedures. Can we begin the slideshow? So, a procedure is basically a method of how to do a job. In the morning session, you all learnt about the therapeutic procedures, and now we will be discussing the diagnostic procedures. The main diagnostic procedures which a student should know are the Wood's lamp examination, the skin scraping, a Zank smear, a slit skin smear, skin biopsy, patch testing and intradermal tests, and there are a lot of tests in the sexually transmitted diseases. I will be just telling you very briefly about the dark ground illumination test in syphilis. A Wood's lamp examination. So what is a Wood's lamp? It is basically a device which emits ultraviolet rays at a wavelength of 365 nanometers. The UV light is then filtered through a barium silicate with 9% nickel oxide. This is how the Wood's lamp looks like. You take the patient into a dark room and you on this lamp, and then you see the lesion through the lamp. So the indications of the Wood's lamp are: it is useful to diagnose fluorescent conditions. It also helps in seeing the extent of the disease, and it's very useful procedure for contact tracing, especially in tinea capitis. Tinea capitis, as you know, is a fungal infection of the scalp and the hair. When it occurs in the ectothrix infection, there is pteridine, which is a chemical which is produced when the fungi invade the hair shaft, and this fluoresces. And Microsporum ordwini and Microsporum canis are the organisms which, when the tinea is caused by these organisms, it fluoresces bright blue-green. So when you have a cluster of cases, especially coming from a school, and if you do a Wood's lamp examination, it becomes a very quick procedure to diagnose and do a contact tracing of the different school children who are having the infection, so that they can be adequately treated. The infection by T. schonleini causes a pale green fluorescence. Tinea versicolor, which causes the fungal infection, Pitrosporum versicolor, fluoresces a golden yellow. In erythrasma, which is a bacterial infection caused by Corynebacterium minutissimum, fluoresces a coral red or a pink color. And a Pseudomonas infection fluoresces aqua green, and this is useful for a Pseudomonas infection of the nail. In the hyperpigmented disorders, a Wood's lamp helps to see the extent and to differentiate between the epidermal and a dermal pigmentation. If the pigmentation is only in the epidermis, it will become darker. But if the pigment is confined to the dermal, in the dermis, then there will be no change. For example, as in the case of melasma, if the pigment becomes darker, then it is confined to the epidermis. However, this is not very useful in very dark skinned patients because it becomes difficult to differentiate the darkening of the pigmentation in very dark skinned patients. And in hypopigmentation, such as in vitiligo and the ash leaf macule, which is one of the earliest signs in tuberous sclerosis, are very, you can see the extent very clearly with a Wood's lamp. It is also useful in scabies to identify the burrows. Here what you can do is the papule is painted with a colorless dye which is fluorescein, and it is then washed. The dye goes inside the burrow, and then when you see it with a Wood's lamp, the burrows appear as linear greyish white streaks. Lastly, in drug ingestion, if there is a case where you suspect that the teeth have become yellow, you can examine the teeth if the patient has taken tetracyclines, there will be a yellow fluorescence. Even the nails will show a yellow fluorescence. In the rare disorders of porphyrin metabolism, such as porphyria cutanea tarda, the uroporphyrins, and in congenital erythropoietic porphyria, there will be a pink fluorescence of the teeth. In the vulva, if there is a squamous cell carcinoma, sometimes it shows a bright red fluorescence. And for research purposes, you can also use fluorescent markers to determine the depth of penetration of topical creams. So these are all the indication of Wood's lamp. The next important investigation is the skin. Yes.
Can this be helpful in the cases of vitiligo also, which is ill-determined and like that?
Yes, then there is a very ill-defined patch, especially in the indeterminate vitiligo. Then you can use a fluorescent, the Wood's lamp, and what you will be able to make out the hypopigmentation becomes more prominent. And this sometimes helps in differentiating vitiligo from other causes such as pityriasis alba. Anything else you'd like to add?
Yeah. In porphyria, especially congenital erythropoietic porphyria, when porphyrins are there in the urine also shows fluorescent red color.
Yes.
Under Wood's lamp examination.
Yes, I mentioned it for the uroporphyrins.
Yes. In addition to teeth and bones.
Yes.
Urine can also show the color.
So we go on to the next. This is skin scraping for. This is especially useful for fungal infections. In tinea corporis, a scraping from the scale or the roof of vesicle is taken. Can I have the slide show, please? Can we have the show, please? So a scraping is taken from the scale or from the roof of the vesicle, and it is then smeared on a glass slide. 1 drop of 10% KOH is added, and cover slip is put, and then it is examined under the microscope. For your skin scraping to be successful as a diagnostic procedure, you should take the right sample. That is why I am emphasizing this. In tinea angum, the nail clippings as well as subungual debris, that is the debris which is seen under the nail, is most important. This is taken, and here you use a higher percentage of potassium hydroxide, that is 20%. For tinea capitis, you pluck the hair, and you use this as the sample, or you can take the scales. And in tinea versicolor, the scales are used. For candidiasis, the content of the pustules, and in the case of vaginal candidiasis, with the vaginal discharge, a smear is made from there. So you put the sample on a glass slide, you add a few drops of 10% KOH and put a cover slip, and you examine after a few minutes. And what you see are short branched hyphae in fungal infection. I think this has also been covered earlier, so I won't go into details. And in candidiasis, you can get budding cells or pseudo hyphae. So this is how you take the nail clipping and you scrape the subungual debris. If you see here, this scraping is very important. You scrape this debris and then put it on the glass slide. This is what you see. These are the branched hyphae. You can also use this scraping technique to isolate a scabies mite, especially when the infection is not very obvious. Here what you do is you put a drop of mineral oil in the web of the fingers. The burrow is seen as a small black dot at the tip of a greyish white line. So you prick this black dot, and with a sterile needle you scrape the burrow, and then you examine it under the microscope for the scabies mite. This is the web of the fingers, and from the black dot you scrape it, and you will be able to see the mite. Anything else?
Dr. Niti,
Yes.
can Parker viewing can also be used?
Yes,
for
you can
the,
also use this. Yes.
KH scraping.
Yes.
So, what is the advantage and disadvantage of that?
Well, the advantage is that it is a quicker method and it is more easy to identify.
Sometimes when patient has applied topical corticosteroids, then in tinea especially, this KOH test may be false negative.
Yes.
And when we take out speculum in the case of vaginal discharge, and if we want to rule out bacterial vaginosis or differentiate candidal vaginosis from bacterial vaginosis, if we add a drop of potassium hydroxide on the blade of the speculum, if there is fishy odor, it is suggestive of bacterial vaginosis rather than candidiasis. Any difference in how to differentiate candida from dermatophyte infection in a KOH smear, like branched hyphae, septate hyphae, and spores? And
Yeah, what you get is you get what are they called as pseudo hyphae. So in the pseudo hyphae you will get just small sort of budding cells which are joined together, and of course you can do a culture then.
fine.
Can we have the show again, please? The next is the Zank smear. This is a cytological examination of the skin blisters, and it is used for vesicobullous disorders. Here what you do is you rupture the roof of the blister, then you scrape the base with a sterile surgical blade, you smear it on a glass slide and stain it with the Giemsa stain. And in pemphigus you get acantholytic cells which appear as rounded cells with a large nucleus. And in herpes simplex and herpes zoster you can sometimes get the multinucleated giant cells. Similarly, if you have a pustule, you can just do a very simple bedside examination. You do a gram stain smear from the pustule. You de-roof the pustule, you make a smear and stain it with a gram stain. And if it is an infective pustule, you will be able to see the bacteria and you can identify the type of bacteria. But if it is a sterile pustule, as in the case of pustular psoriasis or subcorneal pustular dermatosis, you will only be able to see the degenerated leukocytes without any bacteria. Before we go on to this, would you like to add anything, sir?
Zank smear examination is very important from the examination point of view. And the students are getting a lot of vesicobullous cases. They must perform and to identify whether Zank cells are present or not in those lesions. So it is an important procedure they should know in detail.
Can we have the show, please? Slide show, please. The next is a slit skin smear. It is done for Hansen's. For a slit skin smear, what you do is you clean the site. You first select your site. Normally, you select the earlobes, the eyebrows, and one or two other sites where the lesions are present. You clean the site with spirit. You make a slit about 5 millimeters long and 3 millimeters deep with a sterile surgical blade. Then you keep on pressing it firmly and wipe till no blood. There is no blood. And then you make a smear on a glass slide and you stain with the Nielsen stain. This is done as a bacterial index for acid-fast bacilli, and you also use the morphological index for activity of the disease.
So would you like to add on to this something, few points?
Yes, they should select different sites and earlobes and at least the sites from the lesions, earlobe and site from the lesions and fingers and nasal area. So at least 6 sites should be selected. These are the things to be kept in the mind when you are doing slit smear examination. And staining procedure is very important, and it should be uniform coloring. And Dr. Niti, could you tell about the appearance of the lepra bacilli on the staining? What is the state of the lepra bacilli, whether they are uniformly stained and they are not uniformly stained?
Yes,
the importance of that.
Yes, when you get very uniformly stained solid rods, then that shows that the bacilli are still active. But when you get small dotted appearance, that is, they are inactive, they are just seen as small points. So this becomes important when you want to, when you are doing it for prognostic values.
Dr. Gupta,
Yeah.
would you like to?
Yeah, and also when they are in bunches, then we call them globi, suggesting a polar spectrum of the disease. And morphological index is important in the follow-up of the patients to see the treatment response. If morphologic index drops more rapidly than bacteriological index, bacteriological index may remain unchanged for 2 years or 3 years, and on the basis of that we may not assess the response to treatment or therapeutic effectiveness.
Yes, so for prognosis you see this.
Yeah.
And even in cases of resistance, when there is resistance, then you may see still some solid staining bacilli. That becomes another important factor.
Right.
But when you are doing a slit smear examination, one should take adequate precaution not to injure himself or herself, and all the aseptic precautions should be taken. Yeah. So that things should also be kept in the mind.
Can we have the slideshow, please? The next is a skin biopsy. It is a process by which a part or the whole of the suspected diseased tissue is obtained for microscopic or other investigations. It is the commonest, the most important and the essential diagnostic procedure which is performed by any dermatologist, and every candidate, every student and anybody who is doing dermatology must know how to do a good skin biopsy. The indications of skin biopsy can be diagnostic. When you want to send the tissue for histopathological examination. It can also be therapeutic. That is, you have a small lesion, you can just excise it, send it for histopathology, as well as you have cured the patient. And it can also be used for prognostic value when in certain conditions we want to see, especially in Hansen's, whether the disease is active or not. There are many different ways of doing a skin biopsy. It can be a shave biopsy. This is utilized for lesions which are pedunculated or they are raised above the surface. You have a punch biopsy, which is one of the commonest procedures. You have a saucerization biopsy, an incisional and an excisional biopsy, where you excise the entire tissue, and you have a clip biopsy for pedunculated lesions. So the question comes, which procedure do I choose? That depends on a lot of factors. One, the most important factor is what is the pathology you are suspecting. If you are suspecting that the pathology is epidermal, the disease is confined to the epidermis, then some of the diagnosis could be either a seborrheic keratosis, in some cases of warts, especially when they are flat warts, or even in pyogenic granuloma, a shave biopsy is sufficient procedure. If the pathology is dermal, such as in psoriasis, in lichen planus, in tumors, in lupus erythematosus, in vasculitis, in erythema multiforme, and in a vesicobullous lesion, you do a punch biopsy. If you are suspecting a subcutaneous pathology such as in paniculitis or in deep tumors, then you do an excision biopsy. And for pedunculated lesions like skin tags, you can do a clip biopsy. There are a few contraindications to doing a biopsy. One is history of bleeding diathesis. Then secondly is an active infection at the site of biopsy. And in a suspected case of melanoma, always avoid an incisional biopsy. In a patient who has keloidal tendency. Now here I'd like to elaborate that there would be many patients who have a keloidal tendency, and the question arises, do I do a biopsy? What if there is a keloid at that site? What we do here is two things. One, if there are multiple lesions, you choose a site which is away from the site where there is a tendency to form keloids, such as the chest, the back or the upper arms, and preferably take a site where keloid formation is not very common. And secondly, if there is just a single lesion and you have to do a biopsy, then you do the biopsy, closely follow up the patient, and you can give an intralesional corticosteroid, what we discussed in the morning, after the lesion has healed. So in that way you can probably prevent keloid from forming. Then in cardiac patients with valvular diseases, one has to take care of infection so that there is no subacute endocarditis. And as I was saying, in the upper trunk, as far as possible, you avoid biopsy to avoid keloid formation. So what is the lesion which you must biopsy? For most diseases, the oldest and the most developed shows the most diagnostic changes. However, in a vesicobullous disease, it is better to biopsy the newest vesicle, especially which has appeared within 48 hours that is a recent vesicle. And in vasculitis, the lesion should not be too old nor too new. And immunological disorders, always remember, you should include part of the normal skin for comparison. So first is the punch biopsy. This is performed with a round disposable punch. Size can vary from 2 to 10 millimeters, and 4 millimeters is the most common site which we use. It is an ideal procedure for diagnostic skin biopsies or for removing small lesions, and it often provides a better cosmetic result than a shave biopsy. This is the disposable biopsy punch. This is the cutting edge, and this is the handle. So after you take consent of the patient, you clean the part with spirit and betadine and then spirit. You give a local anesthesia. Then you determine the direction of the skin tension lines at the biopsy site. This is very important because so that you get a good scar afterwards. And this was emphasized in the morning also by Dr. Somesh. So this is the technique. The punch is held perpendicular to the surface of the lesion, and the skin is stretched at a right angle to the skin tension lines. The instrument is then pressed down into the lesions, and it is rotated clockwise as well as counterclockwise, cutting down into the subcutaneous fat. As you go on cutting down, when you will feel a slight give. This give suggests that you have reached the subcutaneous fat, and this is important to reach that site so that an adequate specimen is obtained. Otherwise, if you send an inadequate specimen, very often you will get the report that the biopsy has to be repeated because the specimen is not adequate. Then you remove the instrument, and then the specimen is gently lifted. You can lift it either with a needle or with a non-tooth forceps, and then a scissors is used to give a sharp cut just below the dermis in the subcutaneous tissue. And then wounds which are 3 millimeters or less can be treated with just a hemostatic agent and then allowed to heal by secondary intention. You can give a simple dressing. And for larger wounds, especially which are more than 4 millimeters, it is preferable to give 1 or 2 sutures to produce a better cosmetic result, especially on the face. The excisional biopsy is a technique where the entire lesion is removed or it is excised, and then it is then sent for histopathological examination. So it has both diagnostic as well as therapeutic values. It is indicated mainly in small to medium sized skin growths, especially in nevi and in early basal cell carcinoma and squamous cell carcinoma. These are the basic instruments of a skin biopsy tray. You have the scalpel handle, this is a Bart Parker handle, this is a 15 number blade, you would have the artery forceps, the scissors, the needle holder, and 2 forceps. So you first give a field block, then you determine the direction of the skin tension lines. You align the long axis of the excision parallel to the skin tension lines. Then using a surgical marking pen, an ellipse is drawn around the lesion to be excised. This is the way you determine the skin tension lines. If the skin is loose, you will see the wrinkles forming. Otherwise, you just pinch the skin, and where you get this wrinkling, this is along the relaxed skin tension lines. So you mark the excision with a surgical pen, and then you perform the biopsy. The advantages of a excision biopsy is that the whole specimen is available for a study. It is both diagnostic and therapeutic at one sitting, and there is primary wound healing because you are suturing it, so you get good cosmetic results. However, the disadvantage is you require a certain amount of operational skill to do this procedure, and if you don't take adequate margins, then recurrence of the disease can occur. A shave biopsy is indicated for superficial lesions. You give local anesthesia, then you compress the lesion with the index finger and the thumb to raise the lesion slightly above the skin surface, and you take a number 15 sterile surgical scalpel blade and you cut the lesion with a saw-like motion. Then hemostasis is achieved with pressure or a light electrocautery, which is followed by dressing. In a saucerization biopsy, this is indicated for slightly deeper dermal lesions. After giving local anesthesia, take a sterile razor blade, is bent in an arc-like form, and it gets a U shape, and then the lesion is excised in a saw-like manner. This is, you take the sterile surgical blade, you cut it into half, and you bend it slightly, forming a U, and then in a saw-like way you excise this lesion. The clip biopsy is indicated for pedunculated lesions like skin tags, granuloma pyogenicum for filiform warts and nevi. In this, the lesion is held by a small forceps and a gentle upward traction is applied, and the base is then snipped with sharp scissors. And sometimes for small lesions you don't even need local anesthesia. It's a very quick painless procedure. The complications which can occur with a biopsy are you can get bleeding, you can get secondary infection or poor cosmetic results. However, if it is done in the right way, usually you get a very good scar. So in conclusion, a skin biopsy is a simple office procedure. It's useful for diagnostic as well as for therapeutic purposes.
Any precaution or any special care to be taken when you are taking biopsy from the oral mucosa or genital mucosa? Can you point out anything for this?
Well, for the oral mucosa, if it is especially on the lips, you can use a small Calesian clamp. It is very useful to make it a bloodless field, and apart from that, bleeding is slightly more, so you give a little pressure and you can do a light cautery. Anything else you'd like to add?
Yeah, for excisional biopsy, which is also therapeutic for skin cancers, I think it is the recommendation that for basal cell carcinoma, the safe margin which is to be removed is 4 millimeter, and it is perhaps 1 centimeter for melanoma and squamous cell carcinoma. Then
and for benign lesions, it's about 1 to 2 millimeters to prevent a recurrence.
Yeah, to prevent a recurrence. Sometimes the skin cancers, especially BCC, they are more widespread than what they look on the surface. So initial curettage to debulk the lesion will help you to judge the extent of the spread of the skin cancer into the subcutaneous tissue or into the dermis. Clip biopsy can, if there is a vessel in the core of the pedunculated lesion. Another simple way to remove it with radiofrequency loop, so that there is no bleeding, because it coagulates the vessel at the same time. So
but if you don't have access to radiofrequency, what you can also do is just take a small artery forceps and crush the base, and then you just clip it above the artery forceps. So there is hemostasis achieved and there is no bleeding.
Yeah, that's a good way. The advantage of radiofrequency is that the collateral damage is very little and the specimen is well preserved for histopathology.
Yes.
Dr. Niti, certain vascular tumors or hemangioma tumors, what precaution you would like to advise to the candidates when they are taking biopsy?
Yes,
like granuloma pyogenicum or hemangioma, like that.
Well, in these conditions, the main thing is bleeding. And if adequate precautions are not taken, this can go on for a long time. In the case of pyogenic granuloma, as I was telling you, what you do is you just you take a small mosquito forceps or an artery forceps and you first clip the base. And you and then you do a shave biopsy of the lesion, and you wait for about at least 10 to 15 minutes till the bleeding entirely stops. But in any vascular lesion, after you release your pressure or the artery forceps, you have to wait and see if there is no bleeding which starts again. Because if it is there, you may either have to cauterize or you may even have to ligate. This is what is most important.
These are very important key points which are to be remembered.
Yes.
Please continue.
Can we have a slideshow, please? Then we come to the patch test. This is a test which is used to detect type 4 allergy, that is allergic contact dermatitis. In this, standardized solution of the allergens are applied on the back. They are then occluded for 48 hours, and after that the patches are removed, they are marked and numbered, and they are inspected at 48 hours to see for any reaction, and also you call the patient again after 96 hours to see if there is any delayed reaction. So this is the patch test which have been applied on the back with standardized solutions. I'm sorry, it's not very clear, but these are the 4 basic reactions patterns which you may see. When there is absolutely normal skin or very little erythema, then it is doubtful. But when the erythema is more, the reaction is stronger, it is 2+. When there is more erythema, there is edema, then it is a 3+ reaction, and when there is a blister formation, it is very severe. And if you just get a lot of irritant reaction, then it is just an irritant and not a contact dermatitis. And similarly, you can do a photo patch test where you apply 2 sets of that patch test series, and after 24 hours you expose one to the radiation, to ultraviolet light, and then you again examine. I haven't gone much into details about the patch test, but I think we can discuss it.
Yes. What are the precautions to be taken before you are taking the patch test for the patient? What precaution you will advise?
Yes, the main precaution is that the patient should not be taking corticosteroids or even antihistamines. It is better to stop them at least 3 to 4 days prior to doing the test, because then you may get a false negative test. The other thing is, sometimes if the reaction pattern is very widespread, then it may be false positive, what we call as an angry back syndrome. That is, you may get a slight irritant reaction where you suspect this when most of the tests are coming positive. So these are the 2 main things which one must keep in mind.
What you do when there is diffuse dermatitis on upper back, then can we take any other side? You can select
another side. You can select the upper arm or the upper inner arm, or even the forearm.
Right.
Or the other thing is, if the entire there is hardly any spare area, you treat the patient, you wait for the reaction to subside, and then you can do a patch test.
Any upper limit of daily corticosteroid dose under which above which we cannot perform this patch testing?
Well, they say about 20 milligrams
of prednisolone is acceptable.
Yes.
Okay.
Can we have the show, please? There are a lot of tests for investigation tests for the sexually transmitted diseases. For broadly, when it is there for the ulcers, what we do is we take a smear from the edge of the ulcer, and we stain this with gram stain and look for the respective infection. The one thing which I would like to tell you here is about the dark ground illumination test for syphilis, because this is very often asked in the exams. Syphilis, as you know, is caused by Treponema pallidum. It is a diagnosis by clinical findings of a painless indurated ulcer in the primary stage and a skin and mucosal rashes in the secondary stage. And you can diagnose this by the presence of organisms by the dark field microscopy in the exudate which comes out from the ulcers. And of course, this can be confirmed by doing the VDRL test, that is finding the antibodies to the organism in the blood. But the VDRL takes about 1 to 4 weeks after formation of the ulcer. So in the early stages, the DGI is a very important test to diagnose syphilis. In the dark field microscopy, what you do is you, with gloved hands, you clean the ulcer with a gauze which is soaked in normal saline. Then you press the ulcer till fluid oozes out. You take a thin slide and put the slide on the fluid. You put a drop of normal saline and you put a cover slip. You seal the edges of the cover slip with Vaseline so that there is no dehydration and the bacilli remain motile. Then you put it on the microscope, you bring the condenser down, you put a drop of liquid paraffin, then you put the slide and the condenser so that the oil touches the slide, and you examine it immediately, first in the 10x and then 40x. So here it is very important that you have to examine immediately after you take the smear before the movement of the Treponema is lost. And what you see is that against a black background, the Treponema pallidum is seen as a thin, spiral shaped and silvery white, moving by either different movements like rotation, by bending, by angulation and change in size. This is how you see. These are the Treponema pallidum. They will be moving. If there is sufficient fluid, then it will be seen as moving around in your field.
So what we get here is that VDRL is the gold standard for syphilis, but since it takes 10 days for the antibodies to appear, so immediately if we have to diagnose, we go for DGI.
Yes, I wouldn't say it is a gold standard, but yes, it is a good procedure on an OPD basis. And if there is in the early stages, as you have also said, it will be negative. So the DGI becomes a very good procedure to diagnose syphilis.
Dr. Gupta, would you like to ask something?
Yeah. a few precautions are necessary. One is that if patient has applied some antibiotic cream or antibiotic ointment, the DGI test will be false negative, because this Treponema pallidum is a very delicate pathogen and sensitive to any antiseptic applied topically. So that we have to first make sure that patient has not applied any antiseptic cream or solution. Then there are some ways to differentiate Treponema pallidum from non-pathological treponemes. Treponema pallidum has cork screw-like movement, bending movement, and rotation movement, which is very characteristic. It is very slowly motile, and that it doesn't disappear quickly from the view when we see under the microscope. So that is how we differentiate. Then value of dark ground illumination is limited in oral mucosa, because oral mucosa is very rich in non-pathological treponemes. So generally it is not recommended to perform when the ulcer is present in the oral mucosa in a patient who had orogenital exposure to syphilis. Then another precaution is that when we express the serum from the ulcer, there should not be any contamination with blood.
Yes.
That otherwise that will be false negative. So blood should be wiped off.
Yes.
And then lesion should be again pinched with a finger and thumb and to express clear serum. Then sometimes when there is no ulcer present on the genitals, or ulcer is at a non-accessible site, especially in a female like on the cervix, and if there is lymphadenopathy, inguinal lymphadenopathy present, there is one method by which this DGI can be performed on the lymph node also. We inject some 0.1 ml of saline into the lymph node, and then after doing light massage, we suck that saline again with the syringe and then examine it under the microscope. We can see sometimes treponemes. Then this can also be performed on other lesions like condylomata lata or secondary syphilis rash also, provided they are moist enough to express the serum, or if there is oozing of the serum. So these are few additional points which we can discuss.
Dr.
And DGI can also be done beside this syphilis in trichomoniasis. One can demonstrate trichomonas on the dark ground microscopic examination, and they are seen very nicely on this fluorescence. And as Dr. Gupta has already mentioned, that when you are examining the syphilitic ulcer or syphilitic lesions, should not be cleaned with the antiseptics, because that will give false negativity. So they should always be cleaned with the normal saline, wiped out, and then the clear exudate to be taken out and to be examined for the dark ground microscopic examination. And these are the important procedures one should remember, because they can be asked in the theory as well as viva, and they will be helpful in the later on in their practice. So all these tests, diagnostic procedures are very, very important.
Thank you, sir.
In addition to this dark ground illumination, the other tests which are necessary to be performed in a case of genital ulcer one is zinc smear, which we have already mentioned.
Yes, for herpes.
For herpes.
Yes.
And then gram smear is necessary for chancroid.
Yes.
And tissue smear with Giemsa staining is necessary for donovanosis.
And one thing what I'd like to add here is when you have a female patient who has vaginal discharge, what we do is we take a single slide, we divide the slide into 3 portions just by a marking pen, and we take the vaginal smear and we smear it on the slide. You take a cervical and a urethral and smear it on the same slide, and we stain this one slide with gram stain. And from this slide you can diagnose a lot of conditions. From the urethral and the cervical smear with the gram stain you can diagnose gonorrhea, and where you get gram negative intracellular diplococci. And from the vaginal smear you can diagnose candida, because they can also be stained very well with the gram stain. You get either budding cells or pseudohyphae, and you can also diagnose bacterial vaginosis, where you can sometimes get clue cells. clue cells are large epithelial cells, and they'll have a lot of bacilli surrounding the cells. And then apart from this, there is an absence of pus cells which are normally seen in a vaginal smear, and there will be an absence of lactobacilli. So this is the way you can diagnose a lot of conditions just by a single slide, staining with gram stain. This is what we find very useful.
I would like to ask, when you were mentioning about the KOH scraping for the dermatophytes infection, can we do some simple test for the tinea capitis hair pull test?
Yes.
What is that?
Yes.
Can you mention about that?
What you can do is, you just when you suspect that there is tinea capitis, you just take a forceps and very lightly just pluck it. If it comes out easily, then it gives a suggestion that this may be infected with the fungus. This is just a simple test you can do. It also helps you to find out whether the patches, the tinea is expanding, and if there are any hidden patches.
Hi.
Yeah, and in hair it is important to differentiate endothrix infection from exothrix infection. That can be done on the basis of presence of spores within the hair shaft or just outside the hair shaft. And pityriasis versicolor has a very typical appearance of spaghetti and meatball. Because of presence of both hyphae and spores, pseudo-hyphae and spores.
Yeah, but practically sometimes it's difficult to see the spaghetti and meatball. It's more in a culture.
Yes.
Here you will just get very short hyphae. The small short hyphae are seen when you do a simple skin scraping.
Ma'am, sir had earlier brought out this question to differentiate between dermatophytes and fungus.
And candida.
And candida. And on microscopy, and you said about the hyphae, and could you please elaborate more on this? How do you differentiate?
Well, the hyphae which you get in the tinea infection, they are true hyphae. That means they are cells which have a septum in between. But in candida, what you get, they are called as pseudo hyphae because they are not branched out or they are not septate. They are just yeast cells which are joined to each other. So that is the way you can differentiate.
Anything? Ma'am, what about the spores?
In candida, you don't get typical spores. What you get are budding cells. We call them as budding cells. They are double-walled round cells. And one more thing is that budding cells, if you see, are not always significant of candida infection because the candida is a normal common cell. So if you just get a few budding cells, it is not does not imply that the patient has a candida infection. The pseudo-hyphae are more diagnostic. That is one point which should be kept in mind when you see the budding cells.
Dr. Niti, about patch testing, can you tell us more about how should we differentiate an irritant reaction from allergic reaction? Because it is important from therapeutic point of view also.
Well, in an irritant reaction, you'll get there'll be a lot of erythema, you can get vesiculation, and patient will usually have burning, and it comes immediately. As soon as you apply, by within the next 24 hours you will see it, and it is irrespective of the concentration. And this is normally seen when you use a very highly concentrated reagent to do the patch testing. And whereas in a patch test, it develops gradually, unless if the patient has been sensitized quite often or is very highly sensitive.
And generally in patch testing we take two readings,
yes,
as you mentioned, one at 48 hours and one at 72 hours. So what is the purpose of taking this second reading at 72 hours?
Yeah, there are two purposes.
Or some people even recommend another reading at 96
right.
hours.
Yes. There are two things. One is if it is an irritant reaction, then sometimes it will become less as the time goes by. That is one thing. And secondly, there are some reagents which give a very delayed reaction. You may not get a reaction at 48 hours, but you may see it at 96 hours.
Thank you very much, Dr. Khungar, for sharing with us this invaluable piece of information about the diagnostic procedures. And I am sure our DNB candidates would benefit immensely from this information, as diagnosis is the first step towards treating a disease, and if diagnosis is not properly made, we are sure to end up in a blunder. So thank you very much, ma'am. And again, I would like to thank Dr. Gupta, Dr. Sharma for coming here and spending their time with us and taking out from their strict busy schedule. Thank you very much.
Next session.
And the next session would be at 4:30 p.m., 15 minutes from now, by Dr. Vibhu Mendiratta, he would be talking to us about the basic sciences applied to dermatology.